next speaker is Dr. Rika SANTWANI, MD. She's member of the Association for Scientific Field Eye Search, Reproductive Medicine, and the Endometriosis Research Group. Dr. Gynecologist carries more than 20 years extensive experience in obstetric gynecology, infertility, speaker in more than 1,000 webinars. She has written more than 200 articles and for various health journal and newspaper. She has various awards and recognition for her significant contribution in health and social care service. She's going to address endometrial preparation before thawed embryo transfer. Please, the floor is yours.
Yeah. Thank you, madam. Thank you so much, Professor Iman. And from our India, we do the greeting that namaste to everyone, or I can say salam to everyone. So now I'm starting the sharing my screen. And thank you. Please make me host. I'm not able to share my screen. So thank you, Dr. Mustafa, for inviting me here. Yeah. So the topic which I'm going to discuss today is the endometrial preparation before the thawed embryo transfer. I think this is a very, very important topic. Those all who are doing the IVF practice, so this is very, very important. So I tried to make my presentation little simpler also. So as there is a famous quote by the Professor Albert Einstein, do we understand? If you can't explain it simply, you do not understand it well enough. So friends, as we all know, the hard facts, the healthy seeds is not enough to get a healthy sapling unless it is grown on the fertile soil. Similarly, the healthy embryos needs the receptive endometrium for successful implantation. So, as we know, the implantation depends on the embryo quality, endometrial receptivity, and of course, the transfer efficiency. So, regarding this window of implantation, what are the potential for personalized embryo transfer? We can see one by one for the human pregnancy to occur. A normal embryo must implant in the endometrium, and for this has to be happen, the endometrium must be in the receptive state. With significant improvements in the cryopreservation technology, vitrification, the number of frozen embryo transfer IVF cycles are increasing and may surpass in numbers and success rates compared to those of fresh cycles. A small video I've kept for the endometrium. So here we can see once how the movement in the endometrium. So endometrium lining in IVF. So the first successful pregnancy occurred following the frozen embryo transfer has been reported in 1983 by Trosson. The cryopreservation of embryos has become an integral part of ART programs, increased dramatically. The trend towards transferring the fewer embryos after a fresh IVF cycle, and the studies have shown that it is the improved laboratory techniques will give the good results. So friends, the study has been presented in the Fertility Sterility Journal that an endometrial thickness of 9 to 14 mm is associated with a higher implantation and pregnancy rates as compared to the endometrial thickening of less than 7 mm. So there are a lot of studies have been shown regarding this. So if the endometrial thickness is less than 7 mm, how it affects on all the implantation rate, the clinical pregnancy rate, and the ongoing pregnancy rate, and the live birth rate. So the receptive endometrium requires the estrogen priming, need for the endometrial proliferation and development of P4 receptors, the time-related progesterone-induced secretory changes in the endometrium, while the other molecules have also been reported. Among this, the laminin type 4, collagen, integrin, and so many other factors have also been reported. So now for the optimal endometrial preparation for FET cycles, it demands the different endometrial preparation protocols, progesterone support, identification of receptive window of implantation of embryo transfer. These are of most important for ensuring the best results. The success key points in performing FET is the selecting of the proper embryos used for FET, and accurate synchronization of the endometrium and embryos is the key of performing the frozen embryo transfer. So a very important point among this is the age of the embryos after thawing corresponds to the age of the endometrium on the date of the embryo transfer, and the sufficient luteal support is needed. So now what are the different protocols for this endometrial preparation? So friends, we can take one by one the natural cycles or the programmed cycles, or where the ovulation induction has been used. So according to these methods, either with the functioning ovaries, we can use any method, while in the cases where the quiescent ovaries, means where we are using the donor oocyte recipient with ovarian failure or due to some other reasons, only the hormone replacement therapy with estrogen and progesterone. And there are many different protocols has been reported. So among FET, it is only feasible for the women with regular cycles and proven ovulation. In normally ovulating women, the protocol of choice, the simplest method, endocrine preparation of the endometrium, is achieved by endogenous sex steroid production from a developing follicle. While among this true natural cycle, it needs the regular cycles and proven ovulation, involves the frequent monitoring of urine and blood LH levels, early luteal progesterone levels, and the ultrasound monitoring of developing dominant follicle. For optimal FET results, the precise identification of the LH search. Now, what are the disadvantages has been reported with this? Even in women having the regular menstrual cycles, ovulation may not occur always. Problem associated with the detection of a spontaneous LH surge, variation in timing of its occurrence between the cycles and between the patients. And in order to assess the LH levels correctly, the determination should be performed at least daily and preferably twice a day. LH urine kits has a large variation in the thresholds, which involve the risk up to 30% of false negative testing and are often reported by the patients as being difficult to interpret. Now coming to this modified natural cycle. So friends, here, now what to overcome the disadvantages of the LH monitoring, administering the SCG to initiate the luteinization involves the ultrasound monitoring of the developing follicle, measurements of the endometrial strips, of monitoring of serum hormonal levels, followed by 5,000 international units of HCG when the dominant follicle is more than 17 mm and the progesterone levels are low. So here we can see the same what I have spoken. It has been presented by the so many studies. So now what are the advantages and risks associated with this? With the advantages, the less ultrasound evaluation due to the HCG administration compared with true natural cycle frozen embryo transfer. So less burden to the patients and doctors. But now what are the risks expected? Unexpected ovulation, accurate planning of the embryo thawing and transfer is not possible, and the cycle cancellation has been reported 7 to 12%. And sometimes the difficulty in ensuring the timely thawing and embryo transfer. So now, what's the role of this luteal phase support in natural cycle FET? So the different studies have come. Some authors have reported that it is not required, while some studies have shown, there is one study has shown that the higher live birth rate in the patients undergoing the true natural cycle frozen embryo transfer with luteal phase support. So there are two schools of thoughts. Some studies in the favor of that and some studies are not. So now for the what are the methods available there for the preparation? So friends, there are several preparation methods. The estrogen is administered early in the follicular phase in order to induce the endometrial proliferation and inhibit the spontaneous ovulation with progesterone added days before the embryo transfer. So now coming to this programmed artificial cycles, it involves the suppression of natural menstrual cycle with or without the use of GnRH agonist. This requires the exogenous estrogen for the proliferation of the endometrium while suppressing the developing dominant follicle in addition to progesterone replacement and to achieve the adequate secretory changes in the endometrium. So among this, what the protocol has been mentioned by Paulson, that estrogen administration on day 2 or 3 of the cycle, either by incremental or fixed levels, up to 3 tablets until the endometrial thickness on ultrasound has reached approximately 8 mm, and then add of the progesterone 400 milligram PD, and for the number of the days proportional to the stage of the development of the embryo being transferred. So it is the most convenient and respect to limited the monitoring requirements and ease and the flexibility of scheduling. So this protocol is good in the patients with irregular cycles. So now what are the key points among this? We know the endometrial thickness of 6 and showing of triple line is favorable. Endometrial development is unaffected by the length of the follicular phase. No adverse effect of reduction or duration of exposure to estrogen to 6 days or an increase up to 35 days has been reported. So friends, here we know and studies have shown the endometrium is affected by either incremental or fixed estrogen levels, even in the supraphysiologic change. So now coming to the other protocol, the estrogen and progesterones without GnRH agonist used in the females with the remaining ovarian function. Amongst the method what has been prescribed, the estrogen, which helps in the proliferation of endometrium while suppressing the development of dominant follicle. So here the different protocols and methods have been reported: the oral estrogen or the transdermal patches, subcutaneous implants, and vaginal rings or tablets. But here in India, mostly we are using the oral estrogen, and of course in some patients we are giving the transdermal estrogen gel also. So here, as we know, the cycle here you can see from the ecto cycle. So the estrogen has been started from the day 2 of the menses and continue, and progesterone has been added just before the transfer. So the progesterone, the aim is to initiate the secretory changes. It is available either in the form of the oral tablets or the intramuscular or the vaginal suppositories. Yes, the progesterone injections, both the aqueous preparations are also available these days, or in some patients we are using the progesterone intravaginal gel also. So while the routes, the studies have shown no difference in the pregnancy rate between the vaginal and intramuscular progesterone based on the patient and doctor preference. So here what the protocol suggests with the estrogen from day 2 or 3 of the cycle, 3 or 4 tablets, while with the ultrasound, if we see the thickness up to the 9 mm, then the addition of the progesterone. And here, as you see, for the embryo transfer, the blastocyst, the transfer on 6th or 7th day of progesterone, or in the day 3 or morula, the transfer on the day 4 of the progesterone. These are the usual protocols what we are following, and the luteal phase support. So here the different studies have been presented regarding the use of the estrogen. So now what is the protocol suggesting the estrogen progesterone with GnRH agonist in the females with remaining ovarian function? So there are the different methods regarding the use of this GnRH agonist, 37.5 mg. Since there's a mistake, that is 37.5. In regularly menstruating, it is given on day 21 of the cycle. And in oligomenorrheic, from day 1 of the cycle and after 14 days, estrogen is determined and estrogen is started as before. So the different protocols has been for the recipient and frozen thawed embryos. As we have seen, this is day 20 when it is started. And on the from the menses, the estradiol gel or tablet, and as we have just discussed, that before the transfer, we have to start the progesterone. So the studies have shown, this has taken from the Davros and Pados, the endometrial development during the frozen thawed embryo transfer in the woman with irregular endometrial menstruations, development during oocyte and embryo donation with poor or absent ovarian function, absent management of thin endometrium mini-RT. So the studies have shown that estrogen can be administered either in an increasing dose or the constant dose from the beginning of the menstrual cycle. So the doses what has been recommended is up from 6 mg to up to 16 mg has been recommended. So studies have shown that the oral is having a most commonly used and the transdermal route also giving the steady levels of estrogen and most of the physiological even E2 ratio. So as I just discussed, the different formulations are available, the oral, the transdermal gel and patch. Our India is being a tropical country, we are using mostly the oral, and in some patients we are using the transdermal gel in these days. Transdermal patches, I have no experience with that. So here just as I have discussed. Yeah. So among this, oral estrogen increases the hepatic production of TBG, SHBG, triglycerides, and HDL and clotting factor. So it is minimally increased by the transdermal estrogen administration. So friends, in these patients, if the problem of such kind is reported, we prefer the transdermal. So the studies have shown the endometrium may respond differently to a different combination of the estrogenic compounds. So regarding this, vaginal administration also avoids the metabolic effects, but in some patients with vaginal estrogen, the local irritation and discomfort has been reported. And suppose if in these patients we are giving the vaginal progesterone also, that it may inhibit the absorption of vaginal progesterone, which is needed for the development of the endometrium. So there are different studies with the different components has been reported, which are affecting on the estrogen receptor, alpha and beta. So different preparations are available. So among this transdermal estrogen, we can see the studies have shown the more physiologic concentration of estradiol and estrogen metabolites is found with an estradiol-estrogen ratio similar to that of the premenopausal woman with the use of transdermal preparation. So there are different studies with the use of different preparations. This I just discussed. Yeah. Among this, the oral administration of this estrogen, the studies have shown that estrone is a weak estrogen with the lower binding affinity for both alpha and beta estrogen receptors. So studies have shown that with the transdermal route, suggested to be the superior to oral route for the induction of the endometrial receptivity. So yeah, this we already discussed. Yeah. So among this dose schedule, as we have just mentioned, either the 2 mg 3 times a day or up to 16 mg we are using. Here in this chart, everything is mentioned that how we are using. And by the ultrasonic evaluation of the endometrium on the cycle day 11, 12, or 13, if the thickness is more than 8 mm, then we have to continue this progenova and addition of the progesterone. And if it is, if it is more than 8 mm, then some patients are doing the blood sampling of LH and progesterone levels. And if it is less than 8 mm, then we have to raise the doses raise the dose of the progenova, and the protocol is different. It's still increasing the dosage. If it is thickness is not increasing, then to the cancellation of the treatment. So the studies have shown with the higher progesterone levels on the day of the transfer, the single euploid blastocysts were associated with lower ongoing pregnancy rates and lower birth rates. Only few slides are left. So endometrial preparation for third-party parenting and cryopreserved embryo transfer. The studies have shown the differential in the E1 and E2 levels ratio. The transdermal E2 has been suggested to be superior to oral estrogen for inducing the endometrial receptivity and is considered to be more good. So among this frozen embryo transfer, as I just discussed, the different studies with 1.25 gram of estradiol gel, the transdermal is equivalent to 1 mg of estradiol valerate, and 1.25 gram of this estradiol gel is containing the 0.75 mg of estradiol. So friends, these are the different studies has been presented. This is from the very recent, I have taken from the JAMTA Assisted Reproductive Journal 2020. The studies have shown the inactivity cycles with oral or transdermal patches or transdermal gel. There was no significant difference in the pregnancy rates. So there is no difference in the live birth rates between the constant dose versus an increasing dose. Estrogen affects a fresh embryo transfer in oocyte donation cycles with oral or transdermal supplementation. So now, while we are doing this cryopreserved embryo transfer, the studies again have shown in the favor of more in the comparison of the transdermal estrogen compared to oral. So this we have already discussed. Yeah. So among this oral estrogen supplementation duration, the HRT protocol suggests supplement estrogen for up to 2 weeks. And there are different protocols and the different studies have come for the usage of this. There is one study for the prolonged estrogen treatment prior to frozen blastocyst transfer decreases the live birth, has also been by the heterogeneity has been presented. So yeah. So the studies have shown that in frozen thaw cycles, the clinical pregnancy and live birth rates decrease with each decline in the endometrial thickness below the 7 mm and no significant difference in the pregnancy loss rates. So for the duration also, there are different studies has been presented. So now with the duration of the progesterone, the 2 group studies have been presented. In the conclusion, yeah. The studies have shown that warm blastocyst transfer on the 6th compared with the 7th day of the progesterone administration in a HRT cycle results in similar live birth rates. So the studies, this is also has been presented in the Fertility Journal 2020 or the recent data. So this we have already discussed. Yeah. So amongst the summary, we take the studies have shown that there is no difference in the live birth rates between the constant dose versus an increasing dose of estrogen after the frozen embryo transfer in oocyte donation cycles with oral or transdermal supplementation. So friends, the bottleneck is the process of implantation. So endometrium is making of the proper endometrium is also very important for the good results. Implantation is equal to good embryo and good endometrium. So thank you friends for your interest and your time. Thank you so much.
Thank you, Dr. Santwani, for your excellent presentation. And we will postpone the discussion at the end of the session.